Okay, ECG in ischemia. طبعا the fragmentation of ECG into ischemia, arrhythmia, and stuff like that might not be appropriate in the exam. And in the exam, you are confronted by a bunch of ECGs and you don't know. But now we have, we have determined the theme of this ECG as such. So things will be a bit different. And I meant to do it this way because ECG in ischemia is so complicated, by the way. And as we see, as we go through the talk, that there are so many manifestations of ischemia in ECG. We know so well that arrhythmia manifests itself in ECG. Different forms of arrhythmia can be picked up in ECG. ECG is this essential piece of paper for the diagnosis of arrhythmia. Okay. Ischemia, and this is the topic of tonight: chamber enlargement, electrolyte disturbances, special conditions and syndromes. Ischemia is essentially a mismatch between supply and demand. So what we usually have is the decreased supply. Sometimes we have both decreased supply and increased demand. And this is the worst combination. In rare condition, you can have ischemia elicited only by increased demand in face of normal supply. Like if you have extreme anemia, extreme thyrotoxicosis, or severe tachycardia, even if you have normal perfusion, theoretically you might get ischemia because the perfusion is, though it's normal, is overwhelmed by the increased demand. But usually what we have is the decreased supply with or without increased demand. What increases the demand of oxygen consumptions are basically the increased contractility, the increased wall tension, and in the increase in heart rate. We know that the underlying or the underpinning mechanism of acute coronary syndrome is fissure, crack, or erosion of a vulnerable plaque. So this is the very first inciting event. You have a vulnerable plaque, which we need to define what it is. Then it gets cracked or fissured or eroded by some, factors. And then you get the formation of a thrombus, because the fissure or a plaque will set a cascade of reaction that end up in forming a large clot over that fissure. This is not only, there is another side of the story, which is the endothelial dysfunction. Whenever you have an atheroma, especially the vulnerable plaque, you have endothelial dysfunction at the vicinity of that atheromatous segment. And this is again come into play when you have a fissure. So there is an induction of intense vasospasm as well. So we have an acute coronary syndrome because of the fissure, leading to thrombus formation, leading to vasoconstriction. And of course, all patients with acute coronary syndrome should end up in cath lab. This is not only a triage to cath lab. This triage, it has to be timely. So the timeliness of triaging patient to cath lab is paramount. We don't mean that these patients should end up in cath lab anytime. We mean there is a time window that we should stick to. If you are dealing with STEM, you are talking about 90 minutes door to balloon time. If you are talking about non-STEM, you are talking about like 48 hours and stuff like that. So we have to be timely and stick to this timeliness. And this is what you usually see in echo. In cath lab. If you have an acute coronary syndrome, there is an ulcerative plaque, there is a thrombus formation. So the vessel, the RC on the right, is the usual manifestation of acute coronary syndrome in cath lab, and the vessel will be either totally occluded or nearly totally occluded like this. You are probably all familiar with the terminology of ischemic cascade. Uh, Ischemic cascade, by the way, is an important sequence of events that are induced by ischemia. So the entire manifestation, the cascade of the manifestation and the timeline of that cascade. So initially when we have ischemia, there are molecular and perfusion problem that takes place at the cellular level. This will end up inducing diastolic dysfunction, then systolic dysfunction, then STT changes, then the clinical manifestation of ischemia, like angina and MI and stuff like that, chest pain in particular. So that tells us that when a patient has chest pain, already he left behind a long cascade of events, okay? So when he comes with chest pain or she comes with chest pain, she already has gone through the systolic, the diastolic dysfunction, systolic dysfunction, and the perfusion defects. What I want to stress in here, according to the cascade, the diastolic dysfunction precedes systolic dysfunction. And that means the ischemia affects the diastology more than the systology. And some people think that's the reason for that, that diastolic dysfunction, which is a bit ironical or counterintuitive, that diastology is more energy consumption than systology. That's why it's affected earlier and more pronouncedly. This is it. The issue here and what we learned from ischemic cascade is that by the time patient has chest pain, if you do echo, you might not find any, you know, because these stuff are built up on each other. Yes, the foundation is still down, but it's not necessarily present. So at the time of chest pain, if we put a probe on a patient chest, we will not necessarily elicit a systolic or diastolic dysfunction unless we have a certain time limit. That time limit is usually defined as 2 hours from the onset of chest pain. So if the patient has presented within that 2 hours, and if we put a probe and the echo is perfectly normal, we probably rule out ischemia as a cause of his chest pain, because we have to see either systolic or diastolic dysfunction. But if the time from the chest pain, okay, to the time he presented is more than 2 hours, all these preceding events might not be there anymore. So you couldn't find it, you couldn't elicit it, and that will not rule out ischemia. The vulnerable plaque, which is susceptible to fissure, depends on the amount of fibrous tissue and the amount of lipid core. So basically we have 2 main components. Yeah, I know there are cellular elements, there is calcium and all of that. But the most important 2 components of the atheroma are the fat and the fibrous tissue. The more of fatty core and the lesser of fibrous cap, the more vulnerable. You get the point. So fat is bad, fibrous tissue stabilize the plaque. And the vascular remodeling, when the atheroma accumulate in the wall, initially there is a form of extrinsic remodeling. So the atheroma will not encroach upon the lumen, narrowing it. Instead, it goes outside, and instead the vessel might go under a transient stage where the diameter is even bigger than normal. And that's why initial stages of atheroma might be so missed in cath lab, because cath lab is just a luminogram. It sees what's inside the lumen, but it's not missed in cardiac CT. And that's why cardiac CT has sensitivity and specificity and negative predictive value for any plaque approaching 100%, because it sees the wall. The cath lab, I mean the coronary angio, does not see the wall. It sees the lumen, and the lumen take time for it to be narrowed by atheroma because of this vascular remodeling. But in cardiac CT, you could see the wall, so you could see even the extrinsic remodeling and all of that. Type, which part changes with ischemia in this ECG? I wish somebody will answer here. which part changes with ischemia in the ECG?
ST.
Anybody can? ST, okay.
ST interval.
STT interval. So Anna, I wish you will go interactively and don't shy, you know. We are just here for easy going. So feel free to jump in and stop me anytime. And so, yeah, she rested ST. Yeah, probably ST is the most common, but tell you honestly, ischemia can wreak havoc anywhere in the ECG. So this is the very first piece of information I want to deliver, that the ECG and ischemia is everywhere. So ischemic manifestation in ECG can be anywhere. It can be different manifestation. ST shift is one of them, depression and elevation. T wave can be inverted, can be hyperacute, can be pseudo-normalized, meaning it was baseline or pre-existing T wave inversion, and during ischemia it goes upright. This is called pseudo-normalization. This is again a sign of ischemia. Q waves, U waves when they get inverted, yeah, but this is hard to demonstrate. QT interval changes. You might have bundle branch block as a manifestation of ischemia. You can have different form of blocks like what we are going to see, and others. So by and large, ischemia can lead to so many different manifestations in ECG, affecting each and every part of the ECG. So how are we going to do about that? First and foremost, you have to be a clinician when you are holding this piece of paper. Remember to be integratively and to go integrative. Okay, so of course we are not going to describe the ECG in isolation of the patient, but you have always to integrate all things together. It's always valuable to have old ECG to compare. Okay, because pre-existing ECG changes and all ECG changes are not of great significance like the new ones. So if I have an old ECG, that tells me a lot. Fixed and dynamic, yani if I'm following a patient and I have like T-wave inversion and after few hours it disappears, that is probably more significant than if they remain inverted. So the dynamicity of the ECG changes is more important than the baseline ECG changes. The degree and extent, it's always important you describe the ECG changes in terms of what they are and how much. And when we talk about the ST segment depression, it's not enough we say that qualitatively you have ST depression. We have to tell how much of ST depression we have and across how many leads, because that's prognostic as well as diagnostic. Other supportive data is again important, and by supportive data, I mean chest X-ray, the bloods, and the clinical exam, of course, and echo. Sometimes the only way out is echo. Always the clinical scenario, okay? And this is so important because if a patient comes in with, like, say, cough, no chest pain, but I have dramatic ECG changes, I won't be inclined to diagnose angina here, okay? So, and if I have chest pain of pericarditis like characteristic, I might be more assured to diagnose ST segment elevation as pericarditis than as ischemic. Otherwise, I will get lost. Yeah, if I throw an ECG to you with ST segment elevation, yeah, we might play a mental exercise. This is pericarditis, not pericarditis. But honestly speaking, it all boils down to what the actual patient presentation. I won't be reassured to dismiss any ECG as pericarditis unless I know everything about the clinical status of the patient. So the ECG interpretation away from the patient is misleading. Okay, Q waves. Q waves means infarction pattern. Q wave means completed infarction. Q wave means cavity. So the electric signal is going away from that cavity, okay? So Q wave is hateful. Cardiologists don't like it because and they feel so, you know, disappointed when they get Q waves, because it means that there is completed infarction, completed necrosis and stuff like that, and probably it's too late to salvage the myocardium. How we define that this is pathological Q waves? It has to be described in terms of width and depth. The width is more than one small square, and the depth, the easiest way is to compare it to the QRS complex height. So it has to be more than 1/3 of the amplitude, okay? 1/3 or more of the QRS amplitude. So this is pathological. Smaller than that, it can be normal, okay? I'll tell you about that further. Now the ST segment elevation, what does it mean? طبعا نحن usually ST segment elevation is akin to, or it's not akin, it's synonymous to myocardial infarction. But honestly speaking, that's not so accurate, because when we talk about ST segment elevation, we'll talk about transmural injury. An injury could be ischemic and could be non-ischemic. So this heart muscle can come under so many injurious mechanisms, one of which is ischemia. Okay, but you can have ST segment elevation in myocarditis. You can have ST segment elevation in pericarditis. You can have ST segment elevation in intracranial injury. You can have ST segment elevation in whatever. So when we talk about ST segment elevation, we mean precisely injury, and we mean precisely transmural injury, but we just like deal with it like interchangeably with ischemia, because ischemia is the most common cause of ST segment elevation. But let's remember, it's not the only mechanism of ST segment elevation. There are so many other mechanisms. Okay. Now, when we come to the T-wave inversion, I'm so sorry. When we come to T-wave inversion, like T-wave as an important part of the ECG lack specificity to the highest degree. Yani if we talk about the ST segment, shift, elevation, depression, the Q wave, okay, and the T wave, the least specific in the way of ischemia is the changes in the T wave, and can be misleading more than leading. And that's why in ER, we are faced with so many patients because of subtle T wave changes, ischemia or ischemia. We don't have that dispute with the ST segment shift, no, but we have a lot of dispute with the T wave inversion. That T wave inversion lacks specificity in the way of ischemia. It can be because of so many factors, and it could be just non-specific changes. We don't know why it is, but we know it's not significant. Anyhow, the T-wave inversion, the pattern of the T-wave inversion is ischemia, usually is symmetrical. So if you divide the T-wave into two by a midline, by a line in the middle, you see the left and right hand are kind of equal. Because in other conditions like hypertrophy and strain pattern, it tends to be asymmetrical, like I'm going to show you in a bit. The ischemic cycle is a vicious cycle that is set into play when you have ischemia. So initially when you have ischemia, like we said in the ischemic cascade, you have systolic dysfunction, you have diastolic dysfunction, and you have chest pain. The systolic dysfunction decreases the cardiac output, and that increases the catecholamine. That will increase the heart rate and the blood pressure and stuff like that. The chest pain also increases the catecholamine. The diastolic dysfunction increases the wall tension, all of which will lead to increased myocardial oxygen demand, and that will worsen the ischemia. Okay, so whenever ischemia kicks in, it induces loops of more and more ischemia. So ischemia begets ischemia in a vicious way of cycle. Okay, so I think if Dr. Jamal is here, because once he called me for a patient, I have sent for stress echo, sorry, for stress nuclear, it was a SPECT, and he told me that the patient developed ST segment depression during adenosine infusion. Like you see in this ECG, we have ST segment depression in so many leads during the adenosine infusion. Does that mean anything to you? Like, what are you going to do? What's the best course of action if you demonstrate an ST segment depression during adenosine infusion for a patient supposedly going for SPECT? Anybody can answer? Okay.
Can I take that? Yeah.
Okay.
Actually, we're using percentine more than adenosine now. But anyway, it's the same thing, يعني. Same effect. Usually patients who develop these type of changes during the percentine itself, it's during the percentine IV push, which is about, it's a push which is given IV over 4 minutes. We have to wait and see the effect over the recovery time. If they are still developing changes with the symptoms, then we have to comment on that. But the changes that I see in front of me شوية J point وكده يعني changes شوية not very significant.
Okay, طيب, thank you so much. Okay. I'm going to introduce you to the concept which I think is really important to grasp, which is the coronary steal and the role of collaterals. Adenosine, Shiraz, or percentine, like you said, are of equipotent mechanism. They do the same, okay? So what we do when we give adenosine, look at the diagram on the left at rest. We have an artery which is occluded, and we have an artery which is not occluded. When we have this situation, we have collateral between the occluded artery and the non-occluded artery. The blood flows from P1 to P2 through the collateral. Why it moves from P1 to P2? For two reasons. The pressure on the P1 is higher than P2, right? So the blood flows in the collateral according to the pressure gradient. So P1 is more than P2. Why P1 is more than P2? Because when you have an obstruction at the vicinity of P2, the pressure drops down the stream. This is one reason. The other thing, look down at the microcirculation. If you have an obstruction, there is a physiological compensatory mechanism wherever there is epicardial stenosis for the microvasculature to dilate. So it dilates during basal condition, not during stress. It dilates even at rest to compensate for the low flow across the epicardial vessel. So it dilates in P2. So when it dilates down and decrease flow up, the pressure across the entire P2 segment is low. Compare this to P1. P1, the flow is fine, so the pressure is fine, and the microvasculature is contracted. So the pressure is high and the blood moves from P1 to P2. When we give adenosine, what does adenosine do? Adenosine dilates the healthy microvasculature, and it does nothing to the diseased one because the diseased one is already maximally dilated at rest. It dilates no more, it's maxed out. So when we give adenosine, now what we do is we increase the dilatation downstairs in P2 and in P1, and that drops the pressure across P1. And when the pressure drops across P1, the flow gradient from P1 to P2 decrease and might even get reversed. So the blood might flow in the opposite direction from the disease segment to the normal segment, causing a steal. And this results in a significant ST segment changes at the territory supplied by the diseased artery. This is called coronary steal. So coronary steal is a dramatic phenomenon. Okay. During exercise testing, we also have different form of ST segment depression, and we get lost about which is which one is significant. Like here, if we see here, the normal one, the second one is rapidly sloping, which we see a lot. So this is kind of a normal physiological response to exercise to have a minor ST segment depression or rapid upsloping kind of ST segment depression. The one at the bottom is called the slow upsloping, and I'm not going to define exactly what is meant by rapid and slow upsloping, but it's more of quantification. You have to quantify it. All of these are kind of controversial. Compare these to this. Now we have horizontal ST segment depression, down sloping ST segment depression. These are significant. So if you demonstrate this morphology of ST segment depression during exercise ECG, now we're talking about ischemia. Also, if we demonstrate elevation of the ST segment in non-Q bearing leads, but if we demonstrate elevation, ST segment elevation in Q bearing leads, that's not significant. يعني إذا البيشنت أصلاً عنده Q wave and you exercise him and ST segment elevation appears at the Q waves, that doesn't mean a lot. Okay, does not mean ischemia. It means ischemia only if you induce ST segment elevation in a leads without Q waves. Now, if you are unlucky, like in here, in this patient, and you see rest and exercise and you get these changes, what does that mean? This is a full-blown ischemic case induced by exercise, okay? So you can induce ischemia during exercise. Well, probably last session of mine, I have stressed on the use of the Duke normogram, and this is how you use it. I'm not going to elaborate further. Now, let's see here. We have both patients with anterior wall MI. What's the difference between the two? We have ST segment elevation on the left side and the right side. The same extent, like involvement of the leads, more or less it's like the same. So any difference here? Any difference? Okay, I might rephrase my question. Do you think the degree of ST segment elevation varies between the two ECGs? The degree of ST segment elevation, is it different?
Yes, boss. We can see in the left side it's more ST segment elevated.
Very good.
And the Q waves is QRS complexes are kind of wider.
Very good. طيب يا Hamad, does that mean anything to you? Yani if you are confronted with this ECG on the left or on the right, are you going to act any differently, or are you going to feel about the patients differently?
My gut feeling is it's worse scenario in the left side.
Okay, okay,
Yeah.
gut feeling, great, right. طيب, when the ST segment elevation take that pattern, they call it tombstoning of the ST segment. And this is the worst clinical scenario and the worst ECG scenario you get. So initially, by the way, there was controversy around what prognosticate the ST segment elevation. يعني هل ال ST segment elevation الديجري حقها is meaningful? And the studies have proven yes. The more of ST segment elevation you have, the worse the prognosis. So we are talking about, if we go back here, it's the degree of ST segment elevation and the extent of ST segment elevation which counts, okay? The more of ST segment elevation in the ECG, the worse. The higher the ST segment elevation, the worse. Especially when a tombstones like this is the worst scenario, and they call it tombstoning, okay? Now, not gold all that glitters, meaning you can see ST segment depression, deviation, manifestation of ischemia, but they are not of ischemia. So we have to be cautious. Look at this ECG. We have a significant ST segment depression. What do you think about that? Is it ischemia?
I think it's down sloping, so yes, it is.
Yes, it is ischemia. لكن لو لاحظت يا محمد فيها فيتشر مهمة جدا جدا. الاس تي
It's
سيجمنت
AF.
هنا yes, exactly. This
It's
is an
AF.
AF. Yes, AF patient. And we have ST segment depression. But the ST segment depression, the pattern of which is kind of peculiar, and show it to you here. They call it Salvador Dali mustache or reverse tick sign of digoxin. The reverse tick sign or Salvador Dali mustache sign in the ECG. طبعا الرومانتيك terminologies دي خلوها يعني هي scooping. هي scooping like ice cream scoop. لما تكون كده so uniformly scooping is digoxin effect. Not digoxin toxicity, it's just digoxin effect. Whoever taking digoxin might get this reverse tick or scooping of the ST segment, and that is not ischemia at all. This is just the way digoxin shows itself in ECG. Right. Now, what is this? Not ischemia, but this patient is shivering. I have ST segment elevation, subtle, and I have something else, which is?
Hypothermia, form wave.
Exactly.
U wave.
Yes. Yes, it's hypothermia, Osborn waves, and a subtle ST segment elevation. Okay, good. Not ischemia, but some derangement. What is that? I have an impression of ST segment elevation, right? Do you have that
Adam, I
impression?
have a question if you don't mind.
Oh, yeah, sure.
Digoxin toxicity and digoxin effect from the ECG.
Yeah. Digoxin effect is that scooping, is that reverse tick, okay? But digoxin toxicity, the main manifestation, and actually it's probably shown in here, is different forms of arrhythmia, one of which is complete heart block. So when you start to see that this patient is having atrial fibrillation, and now he presented with regular rhythm, they call it regularized atrial fibrillation. That means that this patient develops toxicity, and that toxicity has induced complete heart block. And that's why the pre-existing AF is now regular because of escape rhythm. So whenever you demonstrate an AF which is regularized, raise your red flags. This is toxicity, and keep the digibind bedside. Okay. طبعا there are other forms of arrhythmia which are characteristic of digoxin toxicity. But when we talk about digoxin effect, we are just talking about this reverse tick sign or scooping, and that's it, nothing more. Okay, so back to this one. There is a ST segment elevation, but that's not ischemia, it's something else, which is, anybody can?
Hypercalcemia.
Thank you so much. This is hypercalcemia. Can you tell me why?
Short QT.
Very good. We have short QT, and more precisely, we have short ST. The T wave itself isn't short, but the ST segment has actually vanished. No ST segment. The T wave is just hugging the complexes right away. So this is where hypercalcemia acts. It eliminates the ST segment and brings the T wave closer to complexes. And when the T wave gets fused with the complexes, you have the feeling of elevation. But this is very characteristic of hypercalcemia. Okay. Not ischemia, but chest pain. So what do you think about this? What is this?
Pericarditis.
Why did you say that?
Widespread ST elevation
Okay.
تقريبا with
I think
مش
it's early repolarization pattern.
Early repolarization pattern, exactly. Type. Here, by the way, you are both right. That's why I stressed on the clinical scenario. If I have a patient like this who presented with chest pain and I see this ECG, I will be inclined towards something like pericarditis rather than early repolarization. Okay. ولكن يعني early repolarization والpericarditis, they look alike so much. In this patient, if we focus a little bit, I might show you something here. You see this PR? You see the PR?
Yeah, PR is the
signal?
best.
Yes, thank you so much. Type. Look here. Look at the AVR here. Sorry, where is it? Look at the AVR. What about the PR?
Elevated.
Yes.
elevated.
These are the most specific feature of pericarditis if you can demonstrate. The sagging of the PR in all leads except in lead AVR in which it's elevated. Okay, so if you demonstrate that, you are specifically talking about pericarditis. But again, pericarditis and early repolarization look alike. Okay, now what is this? Now I have seen this T wave that looks like hyperacute T wave, and I think of ischemia because ischemia, especially the STEMI track, it starts with hyperacute T wave. So if this is hyperacute T wave of ischemia, or we are talking about something else.
Hyperkalemia.
This is hyperkalemia, exactly. Why did you say that?
Hyperacute T wave plus the long QT.
Tented T waves.
Tented T wave. Okay. Right.
Hyperkalemia because it has a narrow base. It is not wide.
Very good. Thank you so much. So this is the hyperkalemia T wave. طبعا hyperkalemia and hyperacute, both of which are symmetrical. The asymmetrical one on the right side, on the extreme right side, is considered normal variant. So let's focus on the symmetrical T wave. Can be hyperkalemia, can be hyperacute. It depends on their morphologies. So if the morphology is narrow-based and pointed, tented, this is more in hyperkalemia. If it's broad-based and not pointed and tented, this is the hyperacute T wave of ischemia. Okay, so you see the difference now. Okay. Now, what is this? What is this? Anybody? Any courageous somebody?
Pericarditis.
Pericarditis. Okay.
شكلها saddle shaped كده.
Saddle shaped.
لا ما pericarditis هي ST elevation MI.
ST elevation MI. Okay. This is again the way I'm going to stress on the clinical features, and now and the fact that ECG is not always easy and sometimes really misleading. This is a normal benign repolarization. I know it's extreme form of early repolarization, we know, but this is no more than early repolarization. So sometimes it looks so significantly abnormal to the extent that you might take a patient to cath lab, okay? But it's early repolarization leading to ST segment elevation of that much. Acute pericarditis, like we said, it's so important. The morphology of the T wave elevation is concave, kind of. It's not convex like in the ischemia. And it's diffuse, like we said, diffuse, no reciprocal changes, and we can demonstrate the PR depression like the one you see here. Once you demonstrate the PR depression, you are reassured really specifically this is pericarditis, because it's specific for pericarditis. You don't see it in ischemia, but you see it in pericarditis. And first and foremost is the quality of chest pain. So back to the clinical presentation, the chest pain has to be pleuritic kind of chest pain. You can demonstrate friction rub and all of that, okay? And the ancillary features, like if you do troponin, usually it's negative, like in sometimes it can be positive. And this is again will add to your confusion about the entire thing, because if you have pericarditis, inflamed pericardium might invade in the myocardium and lead to myopericarditis, in which you can have a leak of troponin as well. So high troponin is not going to exclude pericarditis as a diagnosis. And this is complicate the stuff for us. Now, not ischemia, but something big. What is this here? Now I'm seeing two-wave inversion and probably ST segment depression. What is this? Anybody? So this is a hypertrophy pattern, and this is a strain pattern, okay? So this is left ventricular hypertrophy by criteria, the voltage criteria, and we have a strain pattern as evidenced by the T-wave inversion and the sagging of the ST segment. And if you look at lead V1, V2, V3, you could appreciate a subtle ST segment elevation, and this is actually normal with the hypertrophy. So the hypertrophy leads to a subtle ST segment elevation in V1, V2, V3, but most importantly, it leads to T-wave inversion and ST segment depression at the strain pattern in the rest of the precordial leads, okay? So this is again a strain pattern for LVH. And this is, what is this? Again, I have dramatic T-wave inversion and ST segment depression in V1 to V3. What is this?
RVH with the strain pattern.
Yes, this is RVH with the strain pattern, okay? And there are, of course, criteria for diagnosing RVH, criteria for diagnosing LVH, which applies here so much. So I'm not going to go into detail, but this is RVH. My message here is that the T-wave inversion, the ST segment depression, all the manifestation of ischemia can exist with other conditions which are non-ischemic. So you have to know which is which, okay? Now, what is this? I have this ECG. I come across this ECG, and I looked at it just this way. So what's your diagnosis? If you don't have anything about the patient, you don't have any idea about the patient, I mean.
Latent receptor stem.
Yes. Why did you say late? Because of?
Because of QF from
Exactly.
V1 to V4.
Exactly.
With T-wave inversion.
With T-wave inversion and subtle ST segment elevation in the same leads. So in this case, now, if I just throw this ECG to you, you get stuck, you don't know what to do. But if I have a patient like this, and I know patient's history had ischemic heart disease, he went for PCI and stuff like that, I might consider what here?
Aneurysm.
Thank you so much. It might just be LV apical aneurysm, ischemic remodeling advanced that leads to persistence of Q wave and ST segment elevation, and they will remain. The scar remains in echo and the scar remains in ECG. So these changes persist indefinitely, and they are just because of that aneurysm, nothing new, okay? Otherwise, you would have like dealt with this patient at acute STEMI, even late, you might have activated the cath lab. So you have to know. And here is the scenarios or condition when you have to enlist other imaging modalities. So if you are confused about these things, we encourage people to use the echo, because the moment you put the probe, you will see a diffuse scarring of the myocardium and thinning out and clear aneurysmal configuration of the apex, and that's it. You don't have to go any further, okay? Though the ECG is so alarming, but the echo tells you that this is all the standing ischemic remodeling. You don't have to do anything about it. What about this one? Again, it looks like ischemia, but it's not, and the patient had history of syncope. Okay? History of syncope. History of syncope.
Brugada, type 1 Brugada.
Brugada syndrome.
Brugada, yes, Brugada syndrome. So Brugada leads to a special configuration of ST segment elevation in V1 and V2. Okay. Now, this is my masterpiece. This is a patient with ECG after trauma. What do you think first? If I ask you to describe this ECG, what do you think about it? Just descriptively. Okay, it's ST segment elevation approximately everywhere, right? Like precordial and part of the inferior. Okay, no Q wave and sinus rhythm. Believe it or not, this is the effect of intracranial hematoma, intracranial insult. So intracranial insults lead to so many confusion. We have so many patients with massive intracranial insults showing gross changes in the ECG, gross changes in the cardiac biomarker, gross changes in the echo. You don't know what to do about them. That is all reactionary to the intracranial injury. So intracranial injury can lead to ST segment elevation, massive one, and can lead to giant T-wave inversion. That's more usual than this ECG. Okay. I have this patient with chest pain, high troponin, and taken to cath lab, normal coronaries. What do you think about this? This was a patient of stress-induced cardiomyopathy, Takotsubo. Again, it looks like myocardial infarction, and we deal with it just like myocardial infarction. Patient presented with chest pain, subtle T-wave elevation, and sometimes dramatic ST segment elevation, just like every STEMI, and a humble elevation in TNT, troponin. Patient taken to cath lab, normal coronaries. Now, in retrospect, Takotsubo is the diagnosis. In retrospect, so far the diagnosis of stress-induced cardiomyopathy prospectively is hard to establish, and basically, and it remains largely a diagnosis of by retrospect. So you have to do cath, rule out coronaries, then you say this is Takotsubo. Otherwise, it's very hard to tell. So this is Takotsubo. The thing that can tell you from the ECG that this is probably Takotsubo is that you can see changes in the ECG and troponin, okay? And then when you use echo, you are confronted by a discrepancy, or disproportionately, the ECG changes are disproportionate to the amount of damage you demonstrate in echo. يعني troponin يكون عندك 0.2, 0.3, لكن when you do echo, all the segments are akinetic and there is massive ballooning at the apex. You expect that the troponin goes to 5, 6, 10, 8, 9, things like that. But it's just humble elevation in troponin. That's a tip-off. Again, this is a flimsy sign you cannot just rely on just heavily, but it tells you. There are some echo features, we might talk about it later, are confirmatory and gives the diagnosis of Takotsubo, with a great deal of certainty. لكن as far as ECG and troponin are concerned, they look alike to STEMI, and you have to deal with them just like STEMI until you rule out any coronary artery disease. Okay, now why do we get ST segment elevation? ST segment elevation means transmural injury. So the electric current moves towards that segment. So moving towards that electrodes means elevation. Look at the one at the bottom. When we have ischemia, ischemia means endocardial injury. Endocardial, not transmural. When you have it endocardial, the current moves towards it. So when the current moves towards it, it goes away from the electrodes. And when it goes away from the electrodes, it manifests as ST segment depression. So ST segment depression means endocardial injury. ST segment elevation means transmural injury. And we always talk about the J point. The J point is important because that's what takes the ST segment up or drops it down. You have to compare it to the isoelectric line and see how much in millimeter the ST segment is elevated or depressed. Now, if we look at the T-wave morphology, لأنه أنا زي ما قلت لكم بداية الT-wave بالذات lack specificity in ischemia, not like ST segment depression ولا elevation. الT-wave is so misleading لأنها يعني it can encompass so many masqueraders, and you know, like here مثلا non-specific STT changes, biphasic, well, a notched one, well, broad-based, well, flat, and stuff like that. Ischemia, like this one, you see, is symmetrical. In the strain, it's asymmetrical. Okay, it can help you a little to differentiate between the T-wave inversion of ischemia versus strain, the symmetry or lack of symmetry. Now, when it comes to the ST segment depression, we initially said it's not about describing just qualitatively ST segment depression or elevation. We have to go further. The extra mile is you have to tell me the morphology of the depression or elevation and how much. So here are three shapes of ST segment depression. The initial one is called apisloping. The one in the middle, down sloping, and the last one is horizontal or planar. Which one is the most specific of ischemia? Which one? Which one? Huh? Yes?
Down sloping.
Down sloping. Followed by?
Horizontal.
And last?
Upsloping.
Upslope, exactly. So the down sloping is more specific, followed by the horizontal, followed by the upsloping. Okay? يبقى معناتها accuracy of the diagnosis in terms of specificity increases according to the morphology of the ST segment depression and the depth of the ST segment depression. That's why it's important you describe a ST segment depression in terms of morphology and depth. حتى المorphology of the ST segment elevation is not uniform. It can take different forms. These are all ST segment elevation of MI, لكن برضو they are different, okay? It might look like the one on the left or kind of concave, convex, or tombstoning like the one in here. So it has different forms again. Okay. طيب. The timeline for the ECG changes in STEMI. Initially, the one on the left is what you usually have, and as ischemia kicks in, you can have hyperacute T-wave, and we describe that, followed by the ST segment elevation, but still you don't have Q-wave. You don't still have Q-wave. معناتها ما في complete necrosis yet. There is injury, transmural injury, but no necrosis yet to cavitate that segment. Then you start to have the Q-wave and the T-wave inversion. Then the Q-wave persists, the T-wave elevation comes down, the T wave inversion remains. Then later on, you have persistence of the Q wave and normalization of the ST segment and the T wave. And this remains as a scar in the ECG. So persistence of Q wave means necrosis, completed necrosis, and scarring. If it's pathological, by the quantification we have discussed. Now, this is the pericarditis, ST segment elevation, and benign early repolarization, left bundle branch block, LV aneurysm, and Brugada are all leading to ST segment elevation of different morphologies. Not going to go into this one. Now, what about the biphasic T wave? When we talk about biphasic, في بعض الناس بيفتكروا انه biphasic is non-specific. طوالي they relegate it to non-specific and you don't have to be concerned about it at all. في ناس تانيين بيفترضوا no, biphasic T wave is meaningful. And we have to tell exactly, is it inverted or not inverted, according to the second portion of it. A second portion of it tells us about inverted or not inverted. يعني مثلا the one on the right, standing alone, is upright. The one on the left, though biphasic, لكن we call it inverted. Okay? لأنه inverted T wave might be ischemic. So you have to tell me about the terminal portion of this biphasic morphology, if it's upright or inverted. Again, different forms of T wave. I'm not going to go through it. Now, Wellens syndrome. Wellens syndrome, and sometimes they call it proximal LAD disease syndrome. Patient will have history of chest pain, normal or slightly elevated cardiac enzymes, no Q waves, isoelectric ST segment elevation, ما في يعني dramatic ST segment elevation, but you have this pattern. And strange enough, this pattern takes place, or you can see during pain-free state. بمعنى إنه البيشنت لما يكون pain-free, you see these T wave changes. When he is having pain, everything is normal. يعني during pain يحصل لك pseudo normalization of the T wave. لما يكون ما عنده pain, you have this T wave changes. So this is so peculiar, you know. And there are two types of Wellens syndrome. Type A, 25%, and type B, 75%. Type A is biphasic T wave, terminal portion is inverted. Type B is inverted T wave. It's not biphasic, just inverted T wave. This is more common. Type B is more common than type A. So let's see it like that. You see this ECG, this is Wellens syndrome type B, which is more common. And the coronary angio of this patient has shown a significant proximal LAD disease. So Wellens syndrome is called LAD, proximal LAD syndrome. And لكن أهم شيء أذكركم ليها إنه البيشنت لما يكون عنده pain ما ال ECG بتاعه normal. لما يكون pain free, he has these changes. So ironic, okay? So this is the Wellens syndrome. Now the ECG camera. Now this ECG, we have 12 lead ECG. We are seeing the heart from different angles or orientations. What are the two portions in the heart we don't see by ECG? They are considered blind spots. What are these? What are these? The posterior wall and the right ventricle. The posterior wall is from behind, from the back. You don't see it. The surface ECG is all anterior. So you don't see the posterior, okay? The other thing is the right ventricle. The right ventricle is on the right side. And our V1 is overlapping the terminal portion of the RV, but the majority of the RV is still on the right. So the 12 lead ECG misses the right side. And of course, the posterior aspect of the heart. So what can we do about that? If we talk about the location of MI, this is how we do the location. The anterior, septal, lateral, and inferior. Everybody knows about that, okay? Type, if I have an ST segment elevation in V1, V2, V3, 4, 5, 6, when an AVL. What does that mean? What does that mean? Yani, if I have it all here,
anterior, septal, and lateral.
أيوة, يعني if I have it like this, I'm showing it to you here now, this one. Okay. This is called extensive anterior. Extensive anterior, okay? Because the anterior, the septal, the lateral wall, extensive anterior. If I have it just here, anterior, V1 to V2, V3, and sometime V4, I call it anteroseptal, the small one. If it included V6, V5, and V6, I call it anteroseptal lateral, or anterior MI in short. When these leads are involved, extensive anterior. The inferior is easy. It's 2, 3, and AVL. Okay, this is easy. Okay. Okay. Now, these are the leads and what they mean. Now, what about this ECG here? ST segment elevation where? Inferior. So I have inferior wall MI. You agree?
Yes.
What else?
We have ST segment depression in V2 and ABL.
V2 and AVL.
And ABR as well.
So what does that mean?
We may have an inferior posterior.
Okay. So because of this V2, I have high R, ST segment depression, and T-wave inversion in V2 that might indicate posterior. I'm going to tell you why. But basically, I have inferior plus minus posterior extension.
Yeah.
Again, what is this? Inferior, 2, 3, and AVL, inferior wall MI. Agree?
Yes.
You all agree?
Yes, inferior STEMI.
Inferior stem. Okay. What do you think about this?
Inferolateral STEMI with posterior extension.
Okay. طبعا معلش بس لأنه الليدز الجيفن هنا are limited leads. I think it's yes. We cannot tell about the posterior. لكن we can tell we have inferior ST segment elevation. What else? What else in this ECG? Any blocks? Any blocks?
Yeah,
في type. أيوة في type 1.
Is it type 1
type
لكن?
2.
Type 2.
Type 1 fixed prolongation. Fixed
prolongation لكن برضو more important than that, you see you have PPR. You see 2 P's and then the QRS complex. You see the P wave after the T wave and the P wave beside the QRS complexes. Did you see that?
Yeah, we have 2 to 1.
أيوة, this is 2 to 1. So this is high grade block. Okay. طيب يا اخوانا الانفيريور وول ام اي عندها peculiarity in the presentation and peculiarity in the ECG. The peculiarity in the presentation انها مرات بتجي abdominal symptoms. And peculiarity in the ECG انها بتجي ب several forms of blocks. Why is that? لانه بيفترضوا انه the posterior aspect of the heart is heavily populated by vagus innervation. والفيجاس when get stimulated بيؤدي إلى abdominal symptoms وبيؤدي إلى blocks of various forms. عشان كده البوستيريور presentation حقها مرات بيكون صعب والإي سي جي بتاعها بيكون مرات dramatic. Again هنا I have ST segment elevation inferiorly and I have a block. What is this type of block here? What block do I have here?
This is complete heart block.
Yeah, this is complete heart block. Exactly. So inferior wall MI with complete heart block. Great. Okay. This is again inferior wall MI with a benign form of block, which is
Type 1.
type 1. Yeah, this is first degree heart block. So the inferior wall MI can come with blocks, first degree, second degree, third degree, okay? All of them. And now, what is this? What is this? What do we have here? Anybody?
This is inferior posterior lateral.
Very good. Very good. Inferior, posterior, lateral. Very good. Why did you say that? Inferior because 2, 3, and AVL, inferior. Why did you say posterior?
There's ST segment depression in the precordial leads V1, V2 with dominant R wave in V2,
Very
large
good.
R wave, and upright T wave in V2.
And why did you say lateral?
Because there's ST elevation in V5 and 6.
Very good. What else do you have in the CCG?
There's junctional escape or junctional accelerated junctional rhythm. There's P wave and there is junctional tachycardia in between.
لا في AF أظن.
لا ما AF. لو لاحظتوا
We have Mobitz type 2.
ايوه موبيس تايب يعني هي اهم شيء انك انت
First degree.
group beating. You see this group beating? 3 come together and there is some delay. 3, 3, 3. So this is either Mobis type 1 or type 2. Let's focus on the PR. You see the PR here? This is the PR. Now the P comes closer to the T wave, then it gets inside the T wave so we don't see it, then drops, then we start over again. So this is Winkiba. This is inferior lateral posterior MI with Winkiba. Okay? Now, what do we have here? What is this? Okay, leave this one. Don't worry about it now. This is again inferior posterior. What is this? Is it extensive anterior? Yes, it is, because the ST segment elevation V1, V2, 3, 4, 5, 6, 1 and AVL. So it's extensive anterior. What is this? Anteroseptal, because V1 to V4, ST segment elevation. What is this? What is this?
High lateral.
Exactly. This is high lateral. لأنه اللاترال فيه لاترالين. في the conventional lateral and the high lateral, and this is more of semantic لأنه الاثنين نفس المكان ما فرق كبير بيناتهم. يعني if I have V5 and V6 ST segment elevation we call it lateral. If I have 1 and AVL بس ما موجود في حتة تانية, this is high lateral. Okay. طيب, now what do I see here? What is this? Descriptively, what do you see? In terms of ST segment elevation, where does you see that? ST segment elevation. Anterolateral. I see it in V1, in V2, 3, 4, 5, 6, 1 AVL, 2 and AVL. In 2 as well. Do you see it in 2?
Yes, kind of.
Uh-huh. So what is this? Why 2 is involved here? 2 belongs to the inferior. Why do I have ST segment elevation in 2? Or sometimes you have
3.
anterior. Reciprocal changes are usually ST segment depression. لكن if I have ST segment elevation, that is worrisome. يعني I have ST segment elevation extensively anterior. لكن I also demonstrated ST segment elevation في inferior leads. That means something.
Most likely the culprit is the circ.
Okay. Is the culprit the circ? Why do I have extensive anterior? هو في الحالات
ممكن
دي
يكون
ايوه يكون
involving an inferior wall.
Yes, exactly. So here we have 2 scenarios. One is we have a large LAD wrapping around the apex, supplying the inferior wall. So when it gets blocked, we have an extensive anterior as well as inferior, like the one I'm showing you here. Large LAD wrapping around the apex. Or I might have an LAD which is supplying a totally occluded RCA by collaterals. So when we have an acute obstruction in the LAD, we lose the collateral, we lose the RCA as well. So you have anterior and inferior MI simultaneously, okay? Now, what do we have here? It looks like sine waves, but this is not sine wave. This is ST segment elevation of the tombstoning pattern we have talked about and how serious and prognostic that is. And this is extensive anterior tombstoning pattern of ST segment elevation. Okay. And this one is a bit difficult, by the way. Is a bit difficult. يعني تعاين للاي سي جي دي it does not strike you as abnormal, but on further look back, think twice. What do you think about V2? V2.
Yeah, it's slightly in the ST depressed.
Exactly.
Is it true posterior MI?
Yeah,
Yes.
posterior.
This is the problem with posterior. طبعا posterior, it might come in context of inferior, and in this case, no big deal. يعني I already diagnosed the inferior quite clearly by ECG, no confusion. So if I have posterior extension or no, who cares? Patient is going for cath lab anyhow. المشكلة لما يكون عندك isolated posterior and no inferior. In this case, you can easily miss posterior MI. So isolated posterior MI is missable, easily missable, okay? So a patient comes with chest pain and this is ECG, which was declared as normal, لكن the patient is having posterior MI. Okay. مشكلة posterior MI بتظهر في V2 like tall R, ST depression, and upright T, which is considered mirror image of Q wave, ST segment elevation, and T wave inversion. يعني إذا خطيت ال ECG الأول على الميرور, that's what you get. That's why they call it mirror image of ST segment elevation in the posterior. Okay. But this is شكل الposterior MI in V1 and V2. هنا this is posterior MI لكن part of lateral and inferior, so no big deal. لكن لما تيجي isolated هنا بتكون المشكلة. Again, now what is this? This ECG is a bit different. I have inferior ST segment elevation and I have a very important additional feature in this ECG.
RV infarction.
Thank you so much. Why did you say that?
Because of the ST segment elevation in V1.
Very good. Very good. طيب. Now back to the posterior. The posterior aspect of the heart is not seen by the ECG camera on the 12-lead ECG, which are all positioned anteriorly. So if you want to see the right side as the posterior part of the heart, you want to pick up the electricity from the posterior, go posteriorly. So you have to have V7, 8, and 9 below the scapula, okay? You have to do that. And now it's recommended as routine for all inferior wall MI to extend the leads posteriorly, okay? To make sure that if you have it or no. So see, when we have done that, what we get? Look at V7, 8, and 9. Now clear ST segment elevation, okay? Now, what we do about the right side of the heart, which is again blind to the surface ECG. The surface ECG is blinded to the RV. We can have a subtle changes in V1, V2 by ST segment elevation, like the one I showed. Like in so many times, you don't see any, and you have a genuine RV infarction, and you just miss it. Clinically, طبعا, it might be expressive, لكن if you want to demonstrate it in the ECG, shift your lead to the right side like this one. And we call it V1R, 2R, 3R, 4R, 5R, and 6R. So instead of being on the left side, I take them all on the right side. And here is what I get. You see now? This is inferior wall MI. And look at V3R, 4R, 5R, and 6R. I have Q wave and ST segment elevation clearly. معناتها I have clearly ST segment elevation. I have clearly RV infarction. The same is here, right-sided leads and demonstrating ST segment elevation on the right side leads. Last part is how you diagnose MI in context of left bundle branch block, and probably you all know about it and Sgarbossa criteria and طبعا normal left bundle looks like that. When you have an upright, you have T-wave inversion and ST segment depression. And when you have an downward complexes, you have upright ST and T-wave. That is normal. So Sgarbossa criteria بتقول إنه لأنه الليفت bundle صعب تظهر فيه ال ST segment the way it looks conventionally, but we have to have a special criteria for the diagnosis. This special criteria depends on concordance and discordance. يعني مثلا, look at this one here. هنا, ال ST segment elevated. Usually in this part, ال ST segment elevation in left bundle, is it down or up? في this part it is so down. يعني خليني أرسمها لكم عشان نكون واضحين. This one is supposed to be down. So if it gets up by just 1 millimeter, is significant because it has come a long way from being below the isoelectric up to the 1 millimeter above the isoelectric. So if I have concordant ST segment elevation by 1, that means a lot. Concordant. Now look here, sorry. Look at this
دكتور
one.
حاتم معلش أنا عندي سؤال في الحتة دي. الكونكوردنت ST segment elevation في 1 lead بتاخده positive ولا لازم يكون في 2 contagious leads؟ يعني زي الاستمي لازم يكون عندي 2 leads أو 3 leads ولا ممكن في lead واحد أنا بعتبر this Sgarbossa positive؟
هنا طيب, that's good question. Let me show you now. If I show you, let's complete this one. Look at this one here, this part. I have a negative complex, and I have, usually when you have a negative complex, in that complex you have an ST segment elevation normally. Therefore, if I have to diagnose MI, I go for a higher threshold. That threshold should be more than 5. So ST segment elevation discordant, because I have negative and positive. The discordant has to be more than 5. The concordant has just to be more than 1. Now, like the doctora asked, which leads and stuff like that. Let me see here. I don't know how to go. Eraser. Type, sorry. Okay. If you have a concordant ST segment elevation, more than one in a lead with a positive QRS complex, one lead, you give 5 points. If you have ST segment depression more than one, here you have to have V1, V2, and V3 or. بمعنى, I don't have to go for multiplicity of leads. If I demonstrate that in any lead, that's big deal in left bundle branch block. Okay? Discordant ST segment elevation more than 5 in a lead with a negative QRS complex. These are 2 points. If I have any points more than 3, I'm into ischemia within left bundle branch block. Okay? So this is the Sgarbossa criteria. Thank you so much. Thank you. Thank you for all of you.
Thank you.
Okay, shukran, shukran. Thank you very much, Dr. Hatim. Anybody has any more questions? Anybody has any questions or discussion? طيب, shukran, Dr. Hatim, for the very useful lecture, really. And thank you for all the guests and for the interaction. And thank you for the constant support. The next academic activity will be on diabetes and the heart on the same time next week and same link. Welcome everyone. طيب, شكرا. تصبحوا على خير يا جماعة.
Thank you so much. Thanks a lot.
الله يسلمكم. شكرا يا دكتور حاتم.
Thank you very much.
Thank you, Dr. Hatim.
شكرا. شكرا لكم كلكم.